Hi all, welcome back to the second episode of the Neuro Knowledge Podcast. This week's episode will focus on stroke and TIA. I'm your host Scott, and just before we jump into this week's episode and discussion, I would like to point out that the podcast is available on a number of different platforms, including iTunes, Google Play, Spotify, and at neuroknowledge.buzzsprout.com. You're able to subscribe and rate the podcast at any of those outlets, and we'll plan for episodes coming out about every 2 weeks or so, depending on work schedules and so forth. With that, let's jump into this week's topic, which is stroke and TIA. When discussing stroke, it's important to point out that there's two main types of stroke that we're really talking about. There's an ischemic stroke and a hemorrhagic stroke. An ischemic stroke means that there's a lack of blood flow to a portion of the brain, either due to a blood clot, a clot from a cholesterol plaque, or other source. A hemorrhagic stroke is when a bleed occurs within the brain, really within the cranium itself, and this can either be within the brain tissue itself or around the brain. The focus of this podcast will be on ischemic stroke, and a future podcast will focus on hemorrhagic stroke. In regards to ischemic stroke, they represent approximately 70% of all strokes across the world, whereas in America they represent about 87% of all strokes. Each year, approximately 800,000 people or so will suffer a stroke, and of these, 600,000 are first-time or new strokes, whereas 200,000 or so are recurrent strokes. So when a stroke occurs, what is happening is one of the blood vessels that feeds the brain, it becomes blocked off by either a small blood clot or a cholesterol plaque. When this happens, the lack of blood flow to the brain results in death of brain tissue over time if blood flow is not restored in a fairly timely fashion. This death of tissue occurs because the brain is so active on a second-to-second basis. It requires blood flow as well as the oxygen and other nutrients that the blood carries on a continuous basis, and if this doesn't occur, then the brain tissue can die over a fairly short amount of time. A TIA, or a transient ischemic attack, is what occurs when there is a lack of blood flow to the brain for a short period of time, in most cases less than an hour and really less than 15 minutes. But technically, any lack of blood flow to the brain that results in a deficit, such as arm weakness or facial droop, that resolves within 24 hours can be called a TIA. TIAs can often be referred to as mini strokes. However, this is not really an accurate term, as the lack of blood flow in a TIA is usually for such a short amount of time that there's no real death of brain tissue. When we discuss the symptoms of a stroke, it's important to point out that these symptoms can vary quite widely depending on which area of the brain is affected, as well as the amount of brain tissue that's affected. A very subtle deficit could be there, such as just a very mild facial droop, or a more pronounced deficit where someone is essentially comatose and unresponsive. I think important symptoms to keep in mind are really those pointed out by the American Heart Association in their acronym FAST, F-A-S-T. The F stands for face drooping, A stands for arm weakness, S stands for speech difficulty, which could be slurring of speech or difficulty producing speech or understanding speech, and T for time to call 911. I think it's important to point out that also for the T portion, the time where the symptoms began is important, as well as the time that the person was last seen normal. This latter point about when the person was last seen normal is especially true if there's been a large gap in time between when anyone has seen the person suffering the stroke. Once someone is felt to be having a stroke, it is important to call 911 as soon as possible, and when EMT or other emergency services arrive, it's important to convey to them when the symptoms started, but also when the person was last seen at their normal baseline level of functioning. The symptoms pointed out in the acronym really get to identifying very large or potentially large strokes, and so when these symptoms are noticed, it's very important to seek emergency medical attention, because there are interventions that can limit the severity of a stroke if they occur in a timely fashion. Additionally, even subtle deficits or deficits which are there for only a short period of time and then resolve should also prompt a fairly urgent medical evaluation. It's always better to err on the side of caution with these things, because a small event such as a TIA can certainly be a warning sign for an impending stroke. I think this is the first major misconception we can address regarding stroke and TIA. If you do suffer a neurologic deficit that resolves fairly quickly, even if it's something minor, it really should prompt an urgent medical evaluation. This shouldn't be something that's merely brushed off and not sought attention for. There are a host of different risk factors that can increase our risk of having a stroke. Some of them are unmodifiable, or rather risk factors that we can't do anything about, and these include your age, ethnicity, family history, and genetics. Other risk factors which we can treat and can hopefully help prevent a stroke include a variety of things, including smoking, diabetes, high blood pressure or hypertension, elevated cholesterol, and physical inactivity. In addition, there are several other medical conditions which include atrial fibrillation, which is an abnormal heart rhythm, often called AFib, or stenosis in the carotid arteries, the two main arteries on either side of the neck that feed the brain. Cholesterol plaque can build up in these and that can predispose one to developing a stroke. In regards to the different categories of risk factors, I don't think we need to touch on the unmodifiable risk factors to a great degree. I will say that as we age, our risk of stroke increases, particularly once we reach age 80 and above. Additionally, there seems to be, at least in America, a higher risk of stroke amongst African American and Hispanic populations as compared to Caucasian populations. Additionally, for most age groups, men have a higher risk of stroke than women. However, there are several age groups where this is different, particularly women 35 to approximately 45, as well as older than age 85, have a higher risk of stroke compared to men. A family history of stroke, particularly early stroke, would increase one's risk compared to someone who does not have such a strong family history. In regards to the modifiable risk factors, the largest contributor to your risk of stroke is actually high blood pressure or hypertension. When discussing high blood pressure, we also need to discuss elevated cholesterol because they work together to narrow the blood vessels in several ways. Over time, high blood pressure affects blood vessels in two main ways. The vessel wall gradually thickens to compensate for the exposure to such elevated blood pressure over time. This can slowly narrow the inside of the blood vessel and restrict blood flow. In addition, high blood pressure also promotes the formation of cholesterol plaques along the blood vessel wall. So if someone has both high blood pressure and high cholesterol, this can almost act as a twofold increase in terms of the amount of plaque buildup in the vessel over time. The plaque buildup and thickening of the blood vessel wall combine to further narrow the size of a blood vessel and area through which blood can flow, which eventually can lead to the complete blockage of the blood vessel over years or decades. The small blood vessels deep in the brain are fairly narrow to begin with, and so they're particularly susceptible to this type of narrowing. However, it can occur in any artery in the body, including the heart, which can lead to a heart attack. An additional risk factor for stroke is smoking. It's a major risk factor and can increase a person's risk by approximately 2.5 times compared to people who don't smoke. If people ever ask me, what's the best thing I can do for my health, I'd always say quit smoking if they are a smoker. Additionally, reducing sugar intake, particularly sugary drinks, and then staying active, I would say, are probably the top three things. There's no shortage of resources out there to quit smoking, and there's actually several links in the description of the podcast that can be followed if you're looking for resources to quit smoking. Interestingly, those who do successfully quit see a decrease in their stroke risk over time, and actually by 5 years, if that person successfully quits, their increased risk for stroke completely disappears. And so really a maintenance of smoking cessation is really important in order to prevent stroke and reduce stroke risk. An additional risk factor is diabetes. Diabetes can increase a person's stroke risk by about 2 times. Diabetes is also felt to promote plaque formation on the blood vessel wall. It can contribute to narrowing there as well. There are also other factors at play which, with elevated glucose, can promote clumping of platelets, which are a factor in the blood which makes someone more prone to forming small blood clots over time and obviously having a stroke in that setting. Finally, I think one of the big things to address here is physical inactivity as both a risk factor for stroke, but as well as cardiovascular disease of all types, which would include a heart attack, etc. Not being physically active can lead to obesity and development of pretty much all of the previous mentioned conditions over time. You may ask, well, what level of activity is really needed then to stay healthy or promote cardiovascular health? What we would ideally be aiming for is about 30 minutes of moderate to vigorous activity 3 to 5 times per week. And so when trying to discuss what a moderate to vigorous activity level looks like, it's an intensity which would keep your heart rate around 60 to 80% of whatever your maximum heart rate is, and maintaining that heart rate for approximately a 30-minute period. There is a link to different heart rate training zones in the description of the podcast as well as a valuable resource in this regard. Any exercise program should be discussed with your physician, particularly if you do have several medical conditions. Sticking with our discussion about the heart, a number of different heart problems can lead to an increased stroke risk as well. There can be an abnormal heart rhythm, such as atrial fibrillation or AFib, which can increase a person's risk for stroke. The chambers on top of the heart, the atria, usually contract or squeeze in a coordinated fashion to help move blood from them into the lower chambers of the heart, the ventricles, before it's pumped out to the rest of the body. In atrial fibrillation, the atria just aren't contracting properly. I kind of think of it as if they're quivering. When this happens, blood, which usually moves out from the atria quite quickly, can begin to pool, and when this happens, blood clots can form. If these blood clots eventually become loose and make their way to the ventricle, particularly the left ventricle, they can travel anywhere in the body, including the brain, and cause a stroke. I'm sure many of you have seen commercials for blood thinners discussing their use for those with AFib, and we'll discuss those in a few minutes when we discuss treatments for stroke and stroke prevention. In addition to rhythm problems, problems on the heart valves themselves can also lead to strokes. Either an infection, which forms a small but solid mass on the valves called bacterial endocarditis, can cause an increased risk for stroke. These small plaques can break off and travel to the brain or other areas and lead to a stroke in that setting. Additionally, they can form small blood clots on them as well, which can also travel to the brain. There's also non-infectious or non-bacterial valvular problems that can lead to a similar process as well. Much rarer but potential causes for stroke or risk factors for stroke are inflammatory conditions that can affect the blood vessels. Having discussed the risk factors for stroke, I think we can also discuss how we diagnose a stroke or how we determine someone has had a stroke. There's two major points to discuss here. One is actually diagnosing the stroke itself, and then determining the cause of what led to the stroke. So diagnosing a stroke itself is often possible just based off the history and a physical exam. However, imaging of the brain helps us really solidify a diagnosis. A head CT can be used to help evaluate for stroke and is especially helpful to rule out a hemorrhagic stroke or that bleeding into the brain we discussed at the beginning of the episode. In ischemic strokes, we can see changes on a head CT approximately 6 to 8 hours after symptoms develop. What we see on that is just a slightly darker area compared to the surrounding tissue. This is called a hypodensity. Additional imaging is beneficial, though, and an MRI is really the more advanced brain imaging that we like to get in this setting. It can give us much more detailed information. Essentially, if you think of the two scans as two different TVs, a head CT is an older black and white television, whereas an MRI is more of a high definition television or even like a 4K television. And so what we look for on the MRI are brighter areas on specific sequences to determine where a stroke occurred or if a stroke occurred in multiple small locations. The location of where a stroke occurred and if multiple small strokes occur can give us a clue to the cause of the stroke as well. When working up the cause of a stroke or what led to the stroke in the first place, usually multiple tests are needed. We look at a variety of different areas of the body. Blood vessels are examined in a number of different ways. And given how many risk factors we discussed which can impact the blood vessels, this really isn't a surprise. Doctors can evaluate the main arteries supplying the brain or those within the brain itself. A carotid ultrasound is a test that looks at the large arteries in the neck to evaluate them to see if there's carotid plaque buildup. There's also additional tests called a CTA or MRA, and these are essentially extensions of the prior CT and MRI tests which we just talked about. They look closely at the blood vessels and the narrowing within them and really focus in on those as opposed to the surrounding brain tissue, although we can also see that. There are more recently developed scans which can even look at whether a cholesterol plaque is unstable and thereby at an increased risk for causing a stroke as well. These tests can also look for tears in blood vessel walls called a dissection or subtle findings of inflammation within the vessels. We also tend to look at the heart during the workup for the cause of a stroke. What we tend to do here is look at both structural causes that could lead to a stroke as well as any abnormalities in the rhythm of the heartbeat that could potentially lead to a stroke as well. An ultrasound of the heart or echocardiogram is often performed. Depending on the level of suspicion regarding the heart as the source of a stroke, doctors may order an echocardiogram which involves going down the esophagus to get a better view of all chambers of the heart. The esophagus is right behind the heart, and so we can get really close to evaluate all the potential chambers with that test. An echocardiogram can also look at the valves and determine if there's a process there which could be causing the stroke, such as bacterial endocarditis, which we discussed previously. Additionally, if AFib is suspected as the cause of a stroke, a heart rhythm monitor called a Holter monitor is used. This is worn by someone for about 48 hours with small EKG leads on the chest, and it analyzes the rhythm of the heart for any abnormalities, specifically atrial fibrillation. Longer-term monitors can also be used, and those can be worn for up to a month. There's also implantable devices that can be worn for up to 3 years. We also tend to order a number of blood tests, and these really get to trying to identify some of those previous risk factors we discussed. We can check the blood glucoses in a level called the hemoglobin A1C, which looks at how elevated the blood glucose has been over approximately a 3-month period. These are essentially screening tests for diabetes, or to see how well someone with diabetes has had their blood glucoses controlled over the last several months. Additionally, we can test for high cholesterol in the blood, and specifically LDL cholesterol, or the cholesterol that's more prone to forming plaques in the blood vessels. There is additional blood work which is occasionally done to look for a blood clotting disorder if it is felt that this is the likely cause of a stroke. This is usually undertaken in younger patients, such as in their 30s and 40s, who have a stroke with really no other risk factors. Additional blood work can be done to look at a rheumatologic or inflammatory condition if it is felt that that is a likely cause as well. And so if somebody is having a stroke, what exactly can be done? Again, in terms of treatment, we need to discuss two main pathways. There's treatments that we can do acutely if somebody presents shortly after their symptoms begin, and then there's secondary steps we can take to prevent another stroke in the future, or try to prevent a stroke from occurring at all if someone has just had a TIA. In regards to an acute stroke, or a stroke that has just happened and it is within really 3 to 4 hours of onset, there's a number of things that can be done. When someone presents to the hospital, this is why it's so important to know that both the time of onset and the last time that they were known to be normal. If this is within 3 hours, a medication called TPA, which effectively is a blood clot buster, it works to break down blood clots fairly actively when given. If someone presents within 3 hours from the time of their stroke symptoms beginning, they are potentially eligible to receive this medication. Now, there are a number of reasons not to give the medication or contraindications to giving it, and these would include things such as if someone has had a surgery or if someone is on blood thinners. The reason for this is that these people have such a high risk of bleeding from the medication, which is the major side effect, including bleeding into the brain, that the risk of giving it and creating a bleed outweighs the benefit of potentially improving the stroke symptoms. I think this is a big important point again to stress is really trying to nail down when the time of the symptoms began, but also when the person was last known normal. I think it's also important that, if a loved one is having a stroke, that somebody from the family can go along with them to the hospital if they're not able to speak for themselves or not able to communicate. The major reason for this is because a consent needs to be obtained because of the risks of the TPA, which are the risks of bleeding. And this means that either a family member or the patient themselves need to be able to say that yes, they accept the risks of such medication. An additional treatment that can be done, and this can be done for a little bit longer after stroke symptoms have developed, typically within 4.5 to 6 hours. However, there's some research saying that this treatment may actually be beneficial further out. This treatment is called mechanical thrombectomy, and essentially what is done here is a small catheter is inserted through the femoral artery in the groin, and this is forwarded all the way up to the brain through the carotid vessels, and once there, a dye is injected to map where the clot causing the stroke is. The catheter is then advanced farther, and a small basket on the end of it is used to grasp the clot and then remove it back out the same pathway. This treatment can be quite beneficial, however, it is only reserved for larger clots that affect the more proximal vessels within the brain. Now, if someone is unable to make it to the hospital or their deficit is not found or felt to represent a stroke until we're out of the time windows for those two treatments, there's not a whole lot acutely that can be done. The risk of bleeding from either the mechanical thrombectomy or the TPA medication is just too great. And so then the person is typically admitted to the hospital. I think at this point it's important to point out a common misconception regarding stroke. A person after having a stroke the next day can be quite devastated. I think it's important to point out that the deficits or the problems that they're having at that time aren't necessarily the deficits that will be there going forward. The brain has quite a capacity to heal and recover some of its function. And I think one of the most important treatments that we do for patients is the physical therapy, occupational therapy, speech therapy that's provided both in the hospital and then once they get out of the hospital going forward. Working on this early and continuously really provides people their best chance at improving the level of function. I would say that we typically would give people 12 to 18 months to really say what type of recovery they're going to have. Obviously, each person recovers differently, and so some people may have a fairly marked recovery, regaining 90, 95% of their prior function, whereas other people may have less. But typically, someone who does have a stroke has some degree of recovery over that time span. A number of different tests are performed while the person is hospitalized to try to determine what exactly caused the stroke. These are some of the tests we discussed before, including a carotid ultrasound, Holter monitor, echocardiogram of the heart, etc. In this setting, if certain conditions are found, such as high blood pressure or elevated cholesterol, perhaps a new diagnosis of diabetes, medications can be used to help treat these risk factors and prevent a second stroke. In terms of high blood pressure, obviously different medications can be used to lower the blood pressure. In terms of cholesterol, there are statin medications such as atorvastatin or Lipitor, or rosuvastatin or Crestor, that can be used to lower the cholesterol, particularly the LDL cholesterol, and help try to prevent a future stroke. If a new diagnosis of diabetes is found, medications can be used to help control the blood glucose in a better range. This may include insulin, but does not always need to include insulin. Additionally, if someone is a smoker, smoking cessation resources can be provided and strongly encouraged going forward. If it is felt that the stroke was caused by a blood clot or blood clots rather coming out from the heart due to atrial fibrillation, that abnormal heart rhythm we discussed earlier, a blood thinner can be prescribed to help thin the blood and prevent clot formation. Blood thinning medications include warfarin, which is kind of the mainstay of blood thinning, which has been around for some time, along with newer blood thinners such as Eliquis and Xarelto, which also thin the blood. When discussing warfarin, it's important to discuss both the advantages and disadvantages of the medication. Some of the advantages are that it's been in use for decades, and so many providers are quite familiar with it. Additionally, it is fairly cheap because there's generic forms available. An additional benefit, in a way, is that it is a reversible medication, meaning that the effects of it on thinning the blood can be reversed quite quickly if need be. This would be in an emergency situation such as an event with abnormal bleeding or in the event of an emergency surgery. Vitamin K or another medication can be given to reverse warfarin's effect on thinning the blood, and then that emergent intervention can take place. I think one of the major disadvantages, or at least one of the major hindrances that many people find in using warfarin, is the frequent lab monitoring that's required. A level called the INR needs to be checked quite regularly at first, and this measures how thin the blood is. Typically, we're aiming for a particular value, usually between 2 and 3 on that scale. And so at first, that level needs to be checked really every couple of days, but once the steady state of the medication is found, those draws can be spread out more. There are also newer medications which can also be used to thin the blood, and these would include medications such as Eliquis and Xarelto. They work much differently than warfarin, and so there's no lab monitoring which is required, which is the major advantage of the medications. They are also therapeutic with their very first dose. Another advantage is that in a trial which looked at comparing warfarin and these newer blood thinners such as Eliquis, the newer medications were actually found to be better at preventing a stroke with a decreased risk of overall bleeding. The major disadvantage is that with them being a newer medication, the cost of them is so high. It's also more difficult to reverse those medications. They used to be irreversible, meaning there is no agent or no medication that could be administered to reverse their effect on thinning the blood. However, more recently, some medications have been developed that can do this. Unfortunately, some of those medications are not always available in every hospital, particularly in smaller hospitals, and so when taking these medications, there can be a delay in reversing the thinning of the blood in an emergency situation. And with that, I think we made it to the end of another episode of the podcast. Thank you again for joining me this week. In summary, we discussed stroke and TIA. We discussed the major risk factors that can predispose one to having a stroke, which would include high blood pressure, high cholesterol, diabetes, smoking, physical inactivity, and heart abnormalities such as an abnormal heart rhythm. We discussed how we diagnose a stroke, both with head imaging, along with the variety of tests we use to work up the cause of a stroke. We also discussed different treatment options, both in terms of the acute treatment options, which would include TPA or mechanical thrombectomy, along with a variety of medications that we can use to prevent stroke from occurring in the future. I hope you'll be able to join us again in a couple weeks when we discuss seizures and epilepsy. We'll have a special guest on the podcast, and we'll be discussing what it means to have a diagnosis of epilepsy, what are some common misconceptions regarding the diagnosis, and what important information families and patients need to hear with a new diagnosis. Thank you again for listening this week, and we hope to see you then. Thanks. Take care. The Neuroknowledge podcast is meant as an informational resource for patients and their families. It should not be used to diagnose or treat any medical condition. It is not a replacement for medical evaluation. Speakers are employees of Mayo Clinic, and views expressed are solely those of the speakers and do not necessarily reflect those of Mayo Clinic or its subsidiaries.